Hello, thank you for watching this virtual presentation. Right now, I'm gonna introduce the patient just like if I'm introducing the patient to my attending or to my preceptor. Uh, this is an 85-year-old gentleman who came to the clinic today, accompanied by his wife. He's complaining that he's been forgetful for the past 3 months. With the last couple of weeks, things are getting worse. Him being able to forget or not remember the name of important friends and family members. Regarding, despite this, he's still able to maintain. He has activities of daily living. He is able to keep track of all his financial situations. Uh, but he's been this problem has been bothering him and his wife. He has a past medical history and is being treated for hypertension, hyperlipidemia, and diabetes. He's currently on medications, and also uh, uh, there's a family history of Alzheimer's disease on the father. For the rest of the family is unknown. Um, he also reports that there are some problems with urinary problems with incontinence, not being able to urinate, and the wife also has noticed that his gait is being changed for the past couple of days. So we perform a neurological exam. We perform several different exams, including the cranial nerves, the hand, but the most eye-catching was the report of the urinary discomfort and the the inability to urinate constantly. Also, there's an abnormal gait, white-based gait. It's like a shuffling gait, and like similar to like if his feet are glued into the floor. Um, which is going to be explained in more detail as long as we go in and see in the actual note. So the approach to this patient, I have diagnosed the patient and I'm going to be discussing that when presenting the subnote, but this will be my initial presentation. There's concerns about this neurological status of this patient. uh, I have concluded with a main diagnosis and three differential diagnoses, and we determined that this is better for this to refer this patient to a specialist. So here we're going to be reviewing the patient data, the chief complaint, and the HPI real quick. This is an 85-year-old male, like I said, and the chief complaint is my wife is worried I am becoming more forgetful. The HPI is this is an 85-year-old gentleman who presents accompanied by the wife for concerns of forgetfulness. He noticed that he has had increased forgetfulness when performing tasks, for example, going into the room to retrieve something that he forgets later. This has been happening for the past 3 months, and he has noted that it's been progressively getting worse. His wife notes also that he often forgets conversation and forgets names of family members and friends. She also noticed that he recently, within the last couple of months, he has been walking not as usual. He's not well balanced and is unable to, but he's still able to perform activities of daily living and manage his financial situation. So he has a past medical history, like I say, hypertension, hyperlipidemia, and diabetes. Surgical history had a CABG with three vessels in 1999, and a family history concerning about the father that had Alzheimer's disease, also hypertension, hyperlipidemia, and had a CVA. Mother died with unknown medical history, and it was she died when he was newborn. He is on lisinopril 40 milligrams a day, amlodipine 10 milligrams a day, and metformin 1000 milligrams twice a day. He has no known allergies. Social history: patient has never smoked. He denied illicit recreational drugs, denied drinking alcohol, and is a retired police officer. And he practiced safe sex with a wife. His diet described a well-balanced diet, which includes fresh fruits and vegetables, whole grains, and lean meats. And he is able to walk 3 times a day. As a general, we have no weight loss, no weakness, no fever and chills, no change in visions, ears and nose, there's no changes, no changes in dentitions, no sore throats, cardiovascular, no chest pain. There's no shortness of breath, no melena, no hematechesis, no abdominal pain, the urinary discomfort, no frequent urination, no hesitancy. The patient described occasional urinary incontinence, and there's no muscle weakness, no back pain, no joint swelling, or stiff joints. There's no rashes or itches, no increased thirst or hunger. And neurological, he denies dizziness, headaches, numbness, paresthesia, but he endorses occasional incontinence and the abnormal gaits and the forgetfulness. There's no suicidal ideations, no sadness, no anxiety, and no painful and swollen notes, no blood transfusions. I just want to remark the part that the patient is reporting his incontinence. On the physical exam, it was pretty remarkable all around. I just want to point out the fact that the neurological assessment, there's an appropriate sensation to pain, touch appropriateness, and then also the musculoskeletal, the normal gait sensation. There's no tenderness, no palpation. Normal strain on the muscles is plus 5 out of 5. Neurologic is the cranial nerves are normal, appropriate sensation to pain, like I said. Gait is wide base shuffling gait with glued to the floor appearance and external rotation of both feet, difficult multi-step turn, and broad standing base with loss of balance and closing his eyes. Upper limbs with normal movement, and he is oriented times 3. The assessment diagnosis is idiopathic normal pressure hydrocephalus. This is a reversible cognitive impairment characterized by mild dementia, abnormal gait, and urinary incontinence, and the patient is presenting with all of the signs. For differential diagnosis, we have Alzheimer's disease, most common cause of dementia associated with progressive decline on 2 or more cognitive areas such as memory, executive functions, language, personality, and behavior. Patient is also exhibiting some of those. And the fact that the patient has family history of this trait. Frontotemporal dementia, secondary to damage of the frontal temporal lobes associated with changes in behavior, emotional issues. To rule out all those diagnoses, we need several of tests that we're going to be exploring in the next slide. And Parkinson's disease, which is a neurodegenerative disorder affecting the dopaminergic producing neurons, leading to slow movement, tremors, and problems of dementia, which occur problems of dementia. The plan will be to send the patient for some labs, CMP, CBC, HIV, TSH, vitamin B12, and urine culture. We need to refer the patient to a specialist, in this case, a neurologist, for cognitive testing and also neurophysiologist. There's two tests here that most likely will be they can be directed just to rule out, which is the MRI of the brain and a lumbar puncture. We need to follow up with the patient once testing is completed, and follow up close with the wife as well. Thank you. Any suggestions are welcome. If you have any other differentials, any additional labs, they are welcome.